Welcome to this evening's event, Dying with Dignity in New York, the last of our three-part series, End of Life in the Age of COVID. My name is Xavier Coughlin, and I'll be moderating tonight's event. Before we begin, I'd like to acknowledge the Mohican people. It is with gratitude and humility that we acknowledge that the Sanctuary for Independent Media resides upon the ancestral homelands of the Mohican people, who are indigenous peoples of the lands of New York. Despite tremendous hardships and being forced from their lands, today their community resides in Wisconsin and is now known as the Stockbridge-Muncie community. We pay honor and respect to their ancestors, past and present, as we commit to building a more inclusive and equitable space for all. Tonight's event is hosted by the People's Health Sanctuary, a program of the Sanctuary for Independent Media. For those of you not yet familiar with the Sanctuary, we're a nonprofit community organization based in North Central Troy in New York, just across the Hudson River from Albany. We operate a block-wide campus of activities. Our headquarters doubles as a telecommunications facility and performance venue where we host speakers, independent film screenings, and live music. It is also home to 2 recording studios for our community radio station, WOOC 105.3 FM. We host a volunteer-driven nightly news and public affairs show called the Hudson Mohawk Magazine. As part of the Sanctuary for Independent Media's growing Nature Lab, the People's Health Sanctuary's goal is to establish a central space in Troy at the Nature Lab Environmental Education Center to share health skills, provide basic integrative care, and explore ways to build networks of community health. People's Health Sanctuary embraces models of open sharing of health knowledge and empower all community members to seek their independent health goals as opposed to the traditional hierarchical top-down approach of clinical medical medicine or medical practice. Though caring for our elders, our children, or cooking soul-nourishing food for family or friends may not be deemed quote unquote real health care, we know that in fact it's what holds us together and keeps us sane. Lastly, we hold to the belief that a people's health is a revolutionary health, an inherently anti-capitalist framework which can bring forward models of community autonomy and liberation. A reminder that tonight's event is being recorded, and if you have your camera enabled, you could be visible on the recording. We'll also be streaming live to Facebook. Similarly, we'll be making the resources and discussion shared in the chat box available in the future. In order to ask a question or chat with the panelists or attendees, look to the bottom of your screen. You'll see a chat box and a Q&A box. If you have a question, please type it in the box and we'll call on as many of you as we can to unmute so that you can ask your question. You can also send a private message to someone through the chat function as well. It seems that in the past year, the veil has been ripped off our communal ignorance around death, dying, and inequity. The pandemic has taken a massive toll on the world, in the United States, and within our lives. Amongst all of this unveiling, we are continually confronted with the centuries of oppression that lie just beneath the surface in American history: the racism, the classism, the sexism. Remember their names: George Floyd, Breonna Taylor, Ahmaud Arbery, among the thousands slain by police. And now the recent murders of 8 people in Atlanta, with 6 of them being Asian American women, an obviously racially motivated crime. We say their names as well: Delana Ashley Yawn, Paul Andre Michaels, Dayu Fang, Chao Jae Tan, Sun Si Park, Hee-Yun Jae Grant, Suncha Kim, and Young A. Yu. I don't bring these horrors to depress, but rather to place us in context. The original name for the People's Health Sanctuary was the Health Autonomy Clinic. And the term autonomy has often been misused or misappropriated. We refer to its etymology, its own history. Auto meaning oneself, but also of itself. And nomos usually refers to law, but even further back it refers to custom. And some have even said that it refers to a song or a dance. And so then we can think of autonomy as referring to the song of a place, the song of a person. And we argue that to be fully human is to recognize the autonomy of a human, a community, a world, which includes everything from birth to death. And returning to the topic of tonight, we live in what Stephen Jenkinson refers to as a death-phobic culture. But to be human, to be in this world, means we must turn to face the song of that place, both the joys of the birth and the sorrows of the death. And just as we may face the world in its entirety that we find ourselves, so we must face the death that awaits us all. And so I thank you all for taking your time on this beautiful Friday evening for this beautiful and terrifying and unknown journey that I hope we can take together. Tonight's event, again, is entitled Death with Dignity in New York. And as a result of COVID-19, far too many New Yorkers have been forced to confront death, spurring what used to be uncomfortable, avoidable discussions about life and death issues among family and friends. What death looks like when it comes is something far too many of us now think about regularly, yet many of us remain awkward about discussing. I'd like to introduce our panel of speakers as they help us navigate our journey through advanced care planning and also touch on the ideas of what it means to have a good death. Our first speaker, the first person I'd like to introduce is Corinne Carey, Senior State Director for New York and New Jersey, Compassion and Choices. Compassion and Choices is the nation's oldest, largest, and most active nonprofit organization committed to improving care and expanding choice at the end of life. The organization works towards a society where people receive state-of-the-art care and a full range of choices for dying in comfort, dignity, and control. Corinne Carey joined Compassion and Choices as a campaign director in August 2015. She led the successful campaign for New Jersey's Medical Aid in Dying for the Terminally Ill Act, which took effect on August 1st, 2019. Corinne joined CNC after nearly a decade with the New York Civil Liberties Union, where she served as Deputy Legislative Director. At NYCLU, she engaged in advocacy around a wide range of civil liberties issues, concentrating on public health, medical privacy, discrimination, drug law reform, and reproductive rights issues. She led the campaign to pass a 10-point women's equality agenda as co-chair of the New York State Women's Equality Coalition. All 10 points, including strengthening equal pay laws and codifying Roe v. Wade into state statute, have become law. Prior to her tenure at the NYCLU, Corinne was a researcher at the US program at Human Rights Watch, where she focused on access to public housing for people with criminal records, punitive and ineffective sex offender registries, and the treatment of prisoners during Hurricane Katrina. Corinne holds a master's degree in American Studies from the University of Buffalo, and she graduated summa cum laude and first in her class from SUNY Buffalo School of Law in 1998. Volunteering as a political and public affairs correspondent for the Hudson Mohawk Magazine, evening radio show at WOC 105.3, at the Sanctuary for Independent Media in the Capital Region, she's produced more than 100 stories that can be produced on WOOC's podcast. She also lives in Troy, New York. Donna Smith is the Diversity and Inclusion Advisor and State Director for Compassion and Choices. Donna Smith is an accomplished professional with over 20 years of experience in political consulting, legislative advocacy, public affairs, policy, and program management. Donna has been employed by Compassion and Choices for 7 years. She is a Diversity and Inclusion Advisor and State Director for DC and Maryland. In this capacity, she directs CNC's state-based strategy on how to integrate diversity, equity, and inclusion principles into the work, helping to ensure and build culturally competent programming from the outset. She's led the campaign to pass Death with Dignity legislation in both the District of Columbia, which passed in February 2017, and end-of-life option in Maryland. She was the Chief of Policy and Community Programs for 8 years at the Maryland Department of Aging. She led a team of program managers that implemented aging statewide programs for the aging and their caregivers. And Donna was also detailed to work on the White House Conference on Aging as a public relations specialist. A graduate of Tuskegee University and George Washington Law School, she has one son and resides in Laurel, Maryland. And Dr. Mary Applegate is a highly regarded nationally for her work in public health, education, and in maternal and infant health. She served as a public health physician and medical director in women's health at the New York State Department of Health for 14 years, followed by 15 years at the University of Albany School of Public Health as the Associate Dean for Public Health Practice. Dr. Applegate has been awarded statewide and national leadership awards in the fields of preventative medicine and maternal and child health. Her volunteer work with Compassion and Choices takes her to a different part of the life cycle, but still emphasizes her belief in individuals' autonomy during this and other universal life transitions. And now I'd like to give the stage up to Donna as our first speaker on the panel tonight.
Thank you so much, Xavier. Good evening, everyone. You could have spent your day or your evening anywhere, but you decided to join us. So thank you so much. When you think about compassion and choices, I want you to think about the fact that our goals are to improve care, expand options, and empower everyone to chart their end-of-life journey. We have three main components of what we do. One is advocacy, and Corinne will talk in depth about that later on. We introduce legislation across various states on end-of-life, the medical aid and dying legislation. Number two, we provide education on all end-of-life options. And number three, we have a direct services component. You can go to the website if you're facing the end of life as a terminally ill patient or the caregiver or a loved one. You can reach out via our website and contact end of life consultation counselor. Next slide, please. So, being the diversity and inclusion advisor, I'm very keen on the education part. COVID really unveiled some truths we knew to be true anyway, right? About disparities. And just like there are healthcare disparities, there are disparities at the end of life. And so through our education, empowerment, and advocacy series, we educate folks on their end of life options, all of them, which empowers them to be their own best advocate. And so we increase awareness about the value of hospice care and advanced planning. We identify and recognize end-of-life care disparities, and we share our resources. Next slide. So we can put this conversation or this presentation in context. We have a short video on end-of-life planning that we'd like to show you right now.
Different community groups and community leaders to start having these conversations before a time of crisis, so that we are sort of desensitizing ourselves to the subject of death, and taking sort of the fear aspect away from it and the mystery around dying, and really planning for it.
We plan all the time for everything. We plan for birthdays, we plan for weddings, we plan just because. And I think that we need to plan for your end of life.
There are many, many psychological, very positive effects when it comes to planning. Because planning means what? That you have the mind and the will to be able to look into the future. Planning means to be able to look at your goals where you have the ultimate decision, but you do have the opinions and the support of those around you.
Sometimes it get hard, because, you're bumping heads when you start hitting with people's belief systems.
I have noticed that with Blacks that we have a tendency of not to want to talk about death or not even think about death in any way. And so I realize with my members, their knowledge of even making preparation for death is very low, but I tend to add it into my pastoring them. I always have. But as a people, I think we tend to not want to even think about death.
My cousins or relatives used to tell me all the time, man, don't go to the doctor, because when you go to the doctor, man, when they come back from the doctor, they usually die. But they don't understand that what happened was that because you didn't go to the doctor, all of this stuff was going on in your body, and now you add stage 4, and now the doctor says there's nothing I can do. So now I think what we have to do is prepare people and educate people.
Will you have all the answers if that person's in the emergency room or the person has passed? No, but at least you have some kind of roadmap before if you have that conversation, you know? So I think that in a perfect world, to make it run smoother, have the conversation now.
You know, we have to continue to educate, push, and make people really understand and see. You know, the best thing to do is to sit down and have a conversation.
It's a tough subject. It's a tough subject, but when you plan, things run smoother. It won't be perfect, but it'll be smoother.
We have created a lot of tools and resources that really can help foster that conversation and really break down those specific issues that you face at end of life.
So preparation for anything is good. You need to be prepared. So you get prepared by getting the information. That's the value of compassionate choice.
We found that just by even getting the information out there, that we can probably impact some of those disparities because people just aren't aware that they have access to some of these options.
Thank you. Next slide. So a number of the people that were in that video are there. Two of them, the young ladies, Wendy Miner and Brandy Alexander, are staff, Compassionate Choices staff. The others were members of our African American Leadership Council. And so we have formed various diverse councils. We have a Latinx council as well. We're forming a disabilities council, an Asian American, Hawaiian Islander, and Pacific Islander council as well. We are pulling together these community leaders and executives and faith leaders to sort of help us with our outreach and engagement of communities of color, because it's so very important. If we can educate communities of color about all of their end-of-life options, we can empower them to be their own best advocates. And hopefully that will begin to address some of the disparities at the end of life and during life. It will definitely improve care at the end of life with the advanced planning. Next slide. So let's get into it. Let's talk about healthcare disparities. Like I mentioned before, COVID-19 has really brought to light the disparities that were already there. And as you can see from this chart, the death rate among communities of color is large, but so is the hospitalization rate. For African Americans, it's about twice that of others. In the Hispanic community, it's 30.4 in terms of hospitalization and 15.9 in the Asian community. And there are a number of reasons for these disparities. Next slide. It's another chart that explains the death rate for COVID, specifically in New York. Next slide. So some of the disparities that happen at end of life for communities of color is various communities of color, the pain is not treated or it's undertreated. There is more surgery and more treatment. Some of the treatment is unwanted in the last month of life. African Americans tend to die more often on machinery and facilities away from home. And we all know from the studies that everyone prefers to die at home, wherever home is, surrounded by their loved ones. And fewer African Americans get comprehensive end-of-life care. Next slide. Now, some of this is because of implicit bias on behalf of the medical system, and we'll talk a little bit about that. Some of this is because of mistrust of these communities because of the bad treatment from the medical system. And some of that is because a lot of communities of color do not fill out advanced directives, and they don't talk about what they want at the end of life. So you can see from this chart here, white Americans fill it out around 44%, Latinx Americans 29%, Black Americans fill it out around 24%. Next slide. Now, when we talk about advanced planning, we're not just talking about filling out advanced directives, though that's very important. We're also talking about hospice care. So you can see that Caucasians fill out the form 82%, at a rate of 82%. African Americans fill it out at a rate of 8.2%. Hispanics even lower, 6.7. AAPI at 1.8. Native Americans even lower at 0.5. We don't use hospice care even though it is covered on all the federal insurances and most private insurances, but there is a culture around the use of hospice care. And I'm talking right now specifically about the African American community. They feel that if, hospice is a place you go or you send your relatives to die, and it's a form of giving up. They don't realize it's a service you can receive in your home. Next slide. So let's talk a little bit about why there are disparities. Medical provider bias and discrimination. So I'm a graduate of Tuskegee University. You've heard about the Tuskegee University experiment. You've heard about Henrietta Lacks, L-A-X, who was a patient at Johns Hopkins, and her cells have been used around the world to cure a number of things, but they were taken without her consent in the 1940s, around the time that the Tuskegee experiment was going on, and that experiment lasted for 40 years. So because of these, there's a lack of trust in the healthcare system. Because of experiences like this, there's a lack of trust in the healthcare system based on disparative and negative treatment. This lends itself also to negative attitudes toward hospice. There is also a lack of cultural competency from medical providers when they're dealing with diverse patients. And that's something that needs to be addressed. But there's also a lack of communication around end-of-life care. There is a general reluctance to talk about death. And some people have less access to quality and consistent health care due to socioeconomic factors. Next slide. Next slide. So we talked about advanced care planning, right? Advanced care planning is making decisions about the health care you would want to receive if you're facing a medical crisis. And these are your decisions to make based on your own personal values, preferences, and discussions with your loved ones. One of the most important parts of a healthcare directive is for you to name your healthcare proxy. Now, that's very important because if you don't name your healthcare proxy, and you have to name somebody that's going to do what you want them to do, that will honor your wishes. So it's not just about naming someone, it's about naming the right someone. For example, in my early 20s, as soon as I graduated from Tuskegee University, I lost my father. He died. He had a stroke, and he was the center of our family, right? He was our rock. And so I was devastated. And a couple of years later, I was talking to my mother, And as a result of losing my father, I clung to my mother. I just clung to her. And I said half-heartedly, I said, I love you so much, Ma, that I'm never going to let you go. If you get sick, as long as the hospital pays their electric bill, you will be there and I will be there visiting you. And my mother, who is very spiritual, a good Christian, going to church every Sunday lady, almost cursed me out. She said, look here, when God comes to take me, you better let me go. I was shocked. I said, Mama, what are you talking about? You mean you don't want to be with me as long as I want to be with you? And she said, absolutely not. Let me go. And it was the first discussion we had ever had about her wishes at the end of life. And I'm so glad we had them, because I said it in a joking way, but I was serious until she told me what she wanted. And so now I am her healthcare proxy, and I will advocate for Shirley Smith. She will get everything she wants, right? But it took us having that conversation. And sometimes it's even hard to begin to have the conversation, but it's necessary. It's so necessary. Next slide, please. So what does advanced care planning include? Deciding of what types of treatment you would or would not want should you be diagnosed with a life-limiting illness. So you can go from I don't want a whole lot of treatment or barely any to I want all that you can give me. And it's all your decision. It's fine. But you need to first decide what you value, quantity of life or quality of life. You have to go through and have that self-discussion. Once you have it, you need to record it, and then you need to communicate that to your loved ones. And so that's bullet number 2, sharing your personal values with your loved ones. And the time to have these conversations are not in the emergency room. You need to have these conversations when you're in your right mind and are in good spirits and communicate to your loved ones in good spirits so they can receive it. It really takes the burden off your loved ones at the end of life if they're trying to figure out what you would want them to do when they have a set of instructions for you. So completing advanced directives to put into writing what types of treatment you would or would not want and who you choose to speak for you should you be unable to speak for yourself. There's another situation I want to talk about. Now, once you fill out these advanced directives, it's not a one and done situation. You should look at your advanced directives to make sure they still reflect your wishes. So what you want at 25 may not be what you want at 45, and I can guarantee you it won't be what you want at 85. So you have to look at those, and you can change them as much as you would like, but they should reflect your current circumstances, what you want at the time. Things change. Right now, the person that's on my advanced directive is my best friend, Marcia. We're really tight right now, but what happens in 2 or 3 years if we fall out? Maybe I should look at that again and make sure she's not the person who should speak for me if we're not speaking. So it's things like that. As things in your life evolve and change, you should make sure that this document is kept up to date and still reflects your wishes. Next. Benefits of advanced care planning. Your values, goals, and priorities guide medical decisions, not someone else's. And families experience less distress and conflict at the end. It's hard enough losing someone you love, but trying to figure out what they would want makes it even more difficult. And so having that roadmap is very crucial at that time. So I have some resources for you. Excuse me. Alzheimer's and dementia. So African Americans experience Alzheimer's and dementias at a rate twice more likely and Latinx Americans 1.5 times more likely than white Americans. Despite this higher prevalence, they are less likely to be diagnosed by a healthcare professional with these diseases. And while African Americans make up only 13.6% of the US population, they bear 1/3 of the costs associated with care for Alzheimer's disease and other dementias. Next slide. So let's talk about resources briefly. So when you are thinking about filling out your advanced healthcare directive, we have a wonderful tool. It's the end of life care planning toolkit. So this is my end of life decisions. It will take you through defining your values, how to pick a proxy, what type of forms you need. So you need to know that healthcare directives are different in every state. And so you have to get, obviously, the New York State one. But it's just a great tool for you to record what your wishes are and help you to figure out what your wishes are. And you can get that at compassionandchoices.org/end-of-life planning. Next slide. There's a value priorities toolkit. There's a diagnosis decoder. There's a COVID-19 telehealth toolkit, advanced care planning, dying in the age of the pandemic. But for a really quick second, could we hit the diagnosis decoder? This is very important when we talk about how some diseases affect people differently. So if you go to our website and you get on the diagnosis decoder, you can select which one of these you have. Is this a general illness? Is this cancer? Is this dementia? You want to hit dementia? And this toolkit is great because gone are the days when you knew your doctor. You had the same doctor from when you were 10 years old and now you're 45 and he knows you and you have an hour, right, Dr. Mary? Those days are gone. You got 10 to 15 minutes to speak to your doctor. And if you get diagnosed with a serious disease, there may be questions that you need to ask, but you just can't figure out what those questions should be in the 10 minutes. Using this tool, you can put in your information, whether you're a caregiver or a loved one, or you're in the early stages. After you fill out these questions, it will generate for you a list of questions that you may want to potentially ask your doctor so you can get more information about your diagnosis and your prognosis. It's a wonderful tool. Everywhere I go, I talk about this tool because it is wonderful and people have found it very helpful. Whether you're dealing with dementia or cancer or even a chronic illness, it's very helpful. Okay, next. And you can find these resources as well at compassionandchoices.org/end-of-life planning. I think, though I'm over, I apologize. That's the end of my presentation. Thank you so much.
Donna, thank you so much. I have to apologize. I feel a little bit like two people at the same time because I've got one screen going with the PowerPoint. I'm chatting in the other screen. I'm trying to pay attention. And I feel like you all are seeing my real screen and not the PowerPoint. So I'm going to do one thing while I buy myself some time, and I'm going to stop sharing my screen and I'm going to start again. And hopefully this will work a little bit better this time. For some reason, I cannot, for the life of me, make this a full PowerPoint, and I am not sure why. So I just have to apologize to people. Let's see if this does it, and if it doesn't, then we're cooked. All right, we're gonna have to just make do.
Yeah, I think it looks great.
Does it look okay? All right, cool. So let's just go from here. Well, it's one thing to make your wishes known and to know what kind of care you want at the end of life. But in New York, we have a limited number of options for care at the end of life. If you have a terminal illness and you have 6 months or less to live, your choices are limited. You can pursue all kinds of treatment. You can stop eating and drinking. That's called VSED, voluntarily stopping eating and drinking. You can ask the doctor to increase pain medication, and that often results in a loss of an ability to communicate with your loved ones. You can also be placed into what is sometimes called palliative sedation, or basically a medical coma, while food and nutrition are withheld. This idea that many of us have, that we want a peaceful death. We want to die in our sleep, or we want to die surrounded by loved ones with a cool breeze blowing into a beautiful window with the curtains flowing. Sadly, it just doesn't happen. For folks with a terminal illness, a lot of times like cancer or COPD or ALS, the end of life doesn't look picture perfect like that. And the one option that 1 in 5 Americans now has that New Yorkers don't have is the option of medical aid in dying. And that's what we're going to focus the next few minutes on. Medical aid in dying allows a mentally capable, terminally ill adult with a prognosis of 6 months or less to live the ability to request and receive a prescription for medication that they may choose to take to bring about a peaceful death, so long as they're able to self-ingest the medication. So that's medical aid in dying. That's what we're talking about. This option has been made available to people who live in 10 jurisdictions in the United States, 9 states, plus Washington, D.C. And I do want to note here that Donna Smith was responsible in large part for passing the medical aid in dying bill in Washington, D.C. Compassion and Choices has worked really hard on the ground to authorize medical aid in dying in 6 states over the past 5 years. So now nearly 22% of Americans have access to this compassionate option. And the momentum continues. Medical aid in dying laws have been introduced in so many states across the country. And I am so pleased to tell you that my colleagues in New Mexico secured passage of a medical aid in dying bill in both the Senate and the House in that state. And we are waiting for the governor's signature, which it's going to happen. It's going to happen. So New Mexico is going to become the 10th state, the 11th jurisdiction, and Connecticut is not far behind. The bill is moving in Connecticut. And we've also got strong campaigns in places like Massachusetts and other places, and here in New York, which is why we wanted to talk to you all tonight. New York's Medical Aid in Dying Act was first introduced in 2015. It's co-sponsored by Senator Diane Savino from Staten Island and Assemblymember Amy Paulin from Westchester. It passed the Assembly Health Committee in May of 2016, but it sits now as reintroduced for 2021 in the Assembly Health Committee. I forgot to update this slide because every week we're adding new bill sponsors. We've got 48 bill sponsors now in the state assembly. We're waiting for the Senate bill to be introduced, and I can promise you that we're going to have more sponsors in the Senate than ever before as well. So we've come out of the gate strong here in New York, but we are far from the finish line. We got to catch up to some of these other states. Just briefly, the eligibility requirements for medical aid in dying in New York mirror those in other states. Our bill was modeled after Oregon's, which passed in 1994. That law has worked. It hasn't had to be fixed or expanded or, it's just a solid piece of legislation that's been replicated in state after state. And the eligibility requirements are constant across these states. You have to be an adult, 18 years of age or older. You have to have a terminal illness, which in New York is defined as an illness that is incurable and irreversible. You have to have a prognosis of 6 months or less to live. And both physicians that evaluate you, 2 physicians have to make these determinations, and both of these physicians have to be assured that you are capable of making your own healthcare decisions and acting voluntarily. You also have to be able to self-ingest the medication. Each of these bills has a long list of safeguards, and I know I violated every single PowerPoint rule by showing you all of the words on this slide, but it's just to say that there are a lot of safeguards attached to this law. I'm going to point out a few of them. First, the attending physician has to inform the requesting patient of all of their end-of-life care options, including hospice and pain and symptom management. And this is huge because, as I'll tell you a little bit later, New York does a terrible job of making sure that people who are eligible for the compassionate services that hospice has to offer actually get them. We rank 50th. I have that slide later on, but it's despicable. And so this law would require the physician to tell people what all of their options are, including hospice. Another safeguard is that the patient must be able to take the medication themselves. And yes, this does prevent some people at the end from taking it, but this law is about patient autonomy. And we have to be sure as a society, as families, as a legislature, that this is the patient's decision and the patient's decision alone. So this safeguard is really a really important one. Another safeguard is that no physician, no health provider or pharmacist is required to participate. We're not going to talk a lot about the opposition today, but it will come as no surprise to any of you that one of the major opponents to medical aid in dying in New York is the New York State Catholic Conference. Well, I'm Catholic, my family is Catholic, and what I have said to my aunties and my mom is that the day that this bill passes in New York, nothing changes. Nothing changes for people who disagree with medical aid in dying. In fact, in New Jersey, when we passed the law, everyone was Catholic. The bill sponsors, the Senate president, the governor who signed it into law, and our bill sponsor was confronted by the bishop during the campaign in New Jersey. Bishop was very angry that John Berzicelli, the assembly member, was carrying this bill. And when the bill passed, John Berzicelli said to the bishop, "I did my job representing the citizens of the state of New Jersey. You go do your job and consult and counsel your parishioners." And the bishop said, "You're right about that." And that's really what this is about. The law should serve everyone in New York, not just Catholics. And so just a little editorial note there as a Catholic myself. Another safeguard is that if either doctor has any concerns about the patient's mental capacity to make a decision like this, they have to make a referral to a mental health professional for an assessment. And no medication can be prescribed until mental capacity is determined by that mental health professional. So these are some of the safeguards included in the bill. I want to make an important point here that medical aid in dying is not suicide. Professional medical and healthcare associations, as well as organizations dedicated to preventing suicide, have affirmed that medical aid in dying isn't suicide. And you can see some of these groups here. And some of the reasons are these. With suicide, a person sees death as preferable to continuing to live. And with medical aid in dying, a person doesn't want to die, but they know that death is imminent and they want to do that without needless suffering. With suicide, the decision to die is made oftentimes in isolation. With medical aid in dying, the decision to lessen a painful death is discussed freely and thoroughly with doctors and at the patient's discretion with other trusted individuals. With suicide, it's important to recognize that a person who's suicidal is not considered mentally capable to make this decision. A person can't qualify for medical aid in dying unless they're determined to be capable. And with suicide, the person generally dies alone. With medical aid in dying, the person makes their wishes known and they're surrounded by whoever they choose, their loved ones, while they're dying. So very important distinctions between these two. Just a note about the support for medical aid in dying, it is strong across the state of New York. It holds steady from upstate to downstate, through the downstate suburbs, rural, urban. There's more statistics I could show you, but every demographic, every religion, Lifeway Christian Polling Services did a survey about support for medical aid in dying, and Catholics, the people who sit in the pews, support medical aid in dying at 70%. So it's important to keep that in mind. And faith communities and leaders support medical aid in dying too. I just said this, but here's your slide with the citation. I should at some point update these statistics from Gallup. Every year, Gallup puts a survey question about medical aid in dying in their polling. What's really interesting this year, and I wish I had the numbers for you, there was a dramatic jump in support since COVID in the last Gallup poll. I think people, as Xavier said, people are talking about death and dying like never before. So I'm going to stop talking and introduce my colleague, Dr. Mary Applegate, to give you a sense of where doctors stand on this issue. Mary, are you ready?
I'm ready and unmuted. So I was going to start first by talking a little about the perspective I bring to this. As I said, or as Xavier said at the beginning, I'm a public health physician, not somebody involved in one-on-one clinical care. Among public health and preventive medicine physicians, our goals are to help people live as long as they can, as healthy as they can, as happily as they can, but not to sort of artificially prolong life. Another major component of our focus is making sure that communities provide the resources, regardless of what community it is, to help people follow through on their end of life wishes, whatever they are. My own part of public health is maternal and infant health, which kind of upside down from what we're talking about now, but it's very much a mirror image of what we're talking about, because my work in maternal and infant health is all about choice at the beginning of life, healthy births in which the mothers and families and everybody has as much control as possible as they can over the birth experience. Who's going to be with them? Who's going to be doing the delivery? Is it going to be standard sort of high-tech medical care, or is it going to be led by midwives and doulas? Or do they want to be at home, in the hospital, somewhere in between? So it's all about empowering people to make their own choices to the extent possible. So those are the things that I bring, as well as family experience for several generations, seeing what happens without and with thoroughly talked through and spelled out wishes for end of life care. That's not the main thing I was brought here to talk about, though. So Corinne put together a couple of slides. This first one is a poll that was done of physicians themselves, and you'll see at the top, when we're initially asked, do you support medical aid in dying? More than half do, 56%, but 26% are opposed to it, and then others in the middle. After there's explanation of what's entailed in these laws across the country, the total support zooms up to 2/3, and total opposition zooms down to 1 in 5, with some still in the middle. So there's a lot of lack of awareness, even within the healthcare profession, let alone in the general public, about what really is in these medical aid and dying bills, and what Corinne was talking about, all the safeguards there are in place so that people won't be sort of pressured into taking the meds. Nobody's going to make them take it. So lots of safeguards that really provide reassurance to people and make the levels of support go significantly up. Next slide, please. Another group that we have lots of concern about is people living with disabilities. I mean, a huge percentage of the American population, more and more as we get older, live with sort of mild to moderate disabilities. There are also people with really severe disabilities who have to use a wheelchair and other assisted devices from early age until death. So polls have been taken of people with disabilities to see, are they more hesitant than others to accept medical aid in dying? Because there's been an argument out there that people with disabilities in particular are going to be pressured into committing suicide. What was found in the surveys is that that's not at all the case. New Jersey, Connecticut, Massachusetts are all very consistent that people with disabilities are strongly in favor of having access to medical aid in dying. They know what life without being able to make their own healthcare choices is like far too much, because much of the time other people are taking over and either knowing that they can't make an answer or just assuming, oh, you have this disability, you don't know enough here, we'll speak for you. So they really have an interest in going in the direction of medical aid. This is a set of national organizations that share our belief, and the core beliefs being autonomy, independence, and self-determination around these end-of-life choices. As you've seen, there are a lot of echoes among the things that the three of us have been saying, and because those are the core things that we all agree on and that the movement is based on. So next. Oh, these got turned around a little. This is why I support end-of-life choices. As a public health physician, we work particularly at creating community-level resources, both healthcare resources, education, and legal support, such as the medical aid in dying legislation, to allow people to have lives that are as much like the lives they want as possible. Next one. Next one, talked about all of those. And this is a picture of my mother, who died 2 years ago at age 93. And it was kind of the best case scenario. She was 93. She was completely healthy up until 92 and a half when she broke her hip, mentally sharp to the end. And because we had talked extensively over the decades about her desire not to end up like her father had in an intensive care unit with all sorts of machines. And we had gone through and spelled out what she did and didn't want. And then on the final day of her life, she had an event and did have to be taken to the emergency room. But I was able to assure the ER doc that no, this isn't just the crisis of the moment talking. This has been her firm desire for decades. So she was able, up until the very end, to have agency over what happened to her. And it was, I mean, having done this sort of work for many years, it was a very moving experience to be able to be part of the death that we hope for everybody. So, and then a few more details next about what medical aid in dying looks like. Going back to a lot of what Donna was saying, communication is key to this. We should all start today having those conversations, because if you keep putting it off, all of a sudden the decisions are really urgent. Somebody ends up in an emergency room, or they end up with a really late stage diagnosis of something that could have been handled better earlier. So we want to really be able to think through and talk through all of the aspects of these major life decisions before it's a high stress environment. Also, it's a conversation we need to continue, as Donna said, over and over again as we age and as circumstances of all sorts change. Next. The next stage is the preparation steps as the end of life decision is going to be acted on. In terms of requesting medical aid in dying, the patient and their healthcare provider need to have that important conversation. The provider confirmed that the patient is eligible in terms of short life expectancy, as well as physical and mental capability to carry out the act, as well as to make the decision about it. The provider prescribes the medication, the patient puts it in a safe place until it's needed, which often it stays there. And it just provides enormous, psychic reassurance to people to know that if this becomes unbearable, I have an out. So put it in a safe place where you remember it at the time when you do need it. During that period, the healthcare providers talk with the support people, the patient's loved ones, about what they should expect at the end of life. Most of us have not witnessed other people's deaths, And it isn't like you see in the movies that somebody always just falls asleep like Sleeping Beauty or something. So people need to hear, what they can expect, so that they won't be so fearful, and they'll know, what they should do and when they should call for further backup if they need to. Then the last slide about this is the final steps. So when the patient herself decides that it's the right time, not when a family member decides, not when the healthcare provider decides, when the patient decides that it is the right time for her, she gathers her support people around, her family, her closest friends, maybe her doctor or hospice nurse will be there as well to provide support in that final time in the logistical things. So the patient takes the pills herself in her control to the very, very end. And then there is a quiet time that may last for minutes, maybe hours, during which the patient will be able to have those important final conversations with the ones that she loves most, and just gradually drift off and die like I think we would all like to see ourselves dying. Next. The final question is, what about the whole issue of medical ethics? Aren't doctors supposed to treat people and keep them alive? And that's very much the modern take on what our ethical responsibilities are. But there are four major principles that underlie medical ethics. The first one is one that we've heard of in the phrase, first do no harm. The fancy name is non-maleficence, not doing harm to people. The second one is providing care, relieving pain and suffering, which is beneficence, doing good things for people. The next two are very important to this whole conversation. The principle of autonomy, supporting patients' choices as absolutely completely as we can. And then finally, another theme of today is supporting justice, making sure that everybody in the community has access to the ideal kinds of care that they would most like. And it isn't just reserved for the few people who have, perfect health care and have, a totally functional family support service, but it's available to everybody. So those are the ethical considerations that I think of as I talk about and think about these whole issues. I believe that's all of my part. Yes, Corinne, your turn again.
Mary, thank you so much. And sorry, I'm feeling very sloppy with my slide transitions today, but you were fantastic. Thank you. I just want to say a few words in conclusion before we open it up for some questions. First of all, we've got momentum around this issue. You see state after state passing these laws, although not New York yet, because the evidence is extensive and conclusive. If you count evidence from across all of the jurisdictions that have had medical aid in dying, we now have 50 years of combined experience. And these laws have been under a microscope. We've got some really powerful opponents, and there have been no cases of abuse, coercion. No one's been denied life insurance. No one has been taken to court. No one has been charged with medical malpractice. That's really strong evidence that these laws work as intended. Medical aid in dying honors patients' autonomy and protects the doctors who care for them. Very few people, in fact, choose to use the option of medical aid in dying, but so many more, countless others, derive peace of mind simply knowing that it's available. As Mary said, between a quarter and a third of all people who get the prescription never end up using it. And we were talking earlier today, and I said, in this field, as I've been working with dying people and their families, I have never met a group of people more committed to living than I have the people who advocate for and ultimately use or ask for the prescription for medical aid in dying. These are folks who want to live, and they know that their disease is taking all of their control at the end of life. So there are so many people who get the medication and, as Mary said, put it in their cupboard, never take it. But their families report that they had an incredible peace of mind at the end, knowing that that was an option. Adopting New York's Medical Aid in Dying Act will cost the state nothing, but the cost of inaction is tremendous. Many terminally ill people may not try for that one last miracle treatment out of fear that the treatment will be too painful. Far too many have chosen a violent means to end their suffering, rather because they don't have access to this compassionate option. We have so many stories of people's loved ones dying in violent ways, alone, away from their families, because they didn't have any other option. So many others are deprived of the peace of mind that could come with knowing that they could end their suffering if it becomes too great. And as we've seen over the long 6 years of this campaign, people die suffering. It's as simple as that. The New York State Legislature dawdles. They decide not to take this measure up this year. They need more evidence. They need more proof. I can guarantee that the 4 women that we're working with who are terminally ill here now in New York will die suffering. All while families and doctors are powerless with no legal way to respond to their pleas for help. So I'm going to stop it there. Faye Ho Yin is a woman who died a few months ago. She was an advocate for us, and she died suffering. And she didn't have to. If the legislature had picked up and passed this bill last year, she would have had this option. So I always think about Faye and some of our other advocates when I'm giving these talks. So I'm going to stop there, Xavier. I'm going to stop sharing my screen, and I guess we can open it up for questions.
Great. Thank you all so much for your presentations and the information and I think the questions that it brings up. I'd like to leave this up open for questions that are here. We just have one that I see here in the chat, just about statistics around violence endings because of lack of options.
Yeah, it's a good question. There have been no studies here in the United States. We have anecdotal evidence. I've got about 15 stories of people whose loved ones died violently. I mean, I'll tell you 2 of them. One is a 9/11 first responder who worked on the pile. He was a captain with the NYPD. He developed lung cancer. He was on oxygen for about 10 years. And about 2 years ago, he had had enough. And he took a gun and at the entrance of a public park, took his own life. That just did not have to happen. We have a husband and wife from Red Hook, New York. Patty O'Neill, her brother was terminally ill and researched a way to take his own life, didn't tell his family about it, left a note, died alone. Her husband, Ed, Patty's husband, Ed, his sister had breast cancer and asked a very gruesome question when Patty's brother took his own life. She wanted to know how he did it because she knew that she was facing her own painful end. So it happens far too often. There are some statistics from the UK about how many people who commit suicide actually have terminal illnesses, but we don't have those statistics here in the US, just anecdotes.
At this point, I would I'll leave it up to anyone who would like to unmute and ask a question.
Sorry, I joined late, so you may have already talked about this, but I think the saddest cases are when people help loved ones out of grief and help them end their lives and then go on to be arrested and face jury trial. It's such a sad situation where they're doing their best out of love and then they're accused of being murderers.
I'm wondering if my colleague Donna wants to talk about Barbara Mancini. I mean, I can do it. Actually, it's timely because Pennsylvania just introduced a bill to authorize medical aid in dying now. The Pennsylvania legislature is pretty conservative, but you don't have to be a liberal to support this, Medical aid in dying is supported by a broad swath of people, and it really knows no political bounds. Donna, do you want to talk about what happened with Barbara?
Why don't you talk about Barbara? And I have one Marylander, Alexa, that I could share.
Oh, sure. So Barbara Mancini was a nurse, and her father was dying. And she went over to visit with him one day, and he asked her to pass him a bottle of pills. He wanted to, he wanted to take another pain medication, and he took all of them. And it was then that the visiting nurse walked in and saw what happened and called 911. Barbara's father was transported to the hospital and placed on life support, and Barbara was placed under arrest. And she faced prosecution for years before she was vindicated. And the worst part of it all is that her father had an advance directive in place. But because of the circumstances, Barbara's mother had to keep him on life support because she was afraid that her daughter would face not attempted murder charges, but murder charges. So he was kept alive far longer than he ever would have wanted to. Barbara's now a strong advocate, as you can imagine, in Pennsylvania and across the country. And I think wrote a book about this experience as well. If I can find it, I'll put it in the chat. Donna, do you want to share another experience?
Sure. I have a very good volunteer here in Maryland who became a volunteer because her father was suffering at the end of life. And he tried several times to end his life, and he was unsuccessful. He was sick. He had cancer. He kept falling and hurting himself. He was dying. He took pills and he woke up, and it made him even less mobile than he was before. And finally, he called her over one day and said, "You need to come over and say goodbye because I have a gun and this is it." And she came over and they spent some time together, and she had to leave him because if she stayed there till the end, she could have been arrested like Barbara Mancini. And so one of her biggest regrets was not being there for him at the end, but he totally understood and he didn't want her there. But just think about the grief that this family went through. It's so unnecessary. And at this time, why would we let people suffer, the terminally ill patient and their families and loved ones, if we can address it? It just doesn't make any sense. And so, Corinne, I see people are in the chat. They're asking what they can do, like to help you in New York. So I'll turn it back over to you.
Yeah, I placed a link in the chat. The best thing that you can do right now is to send a note to your lawmakers. As you can imagine, if you follow New York politics at all, the legislature is quite preoccupied with some things. And they're also in the middle of passing a budget, which is due April 1st. But when that legislature returns from what they call a spring break in April, we're going to come out of the gate strong, and we need people who support this measure with us. We're going to have a huge campaign with a sign-on letter from doctors and clergy, and a huge presence from statewide organizations across New York, calling for the legislature to pick this measure up and pass it before they leave in June. From April to June, they've got basically two full months. And that time goes by in a snap. They need to hear from their constituents. They need to hear from you if you support this measure. So I did put a link in the chat. I'll do it again, that if you support this, you can send them a note by very easily clicking on this link. Xavier, do we have other questions?
Yes, could I make a question?
Oh, sure.
Yeah, you can ask. And then, we have another question in the chat.
Okay, I'll make it sort of quick. I mean, I appreciate all the great work that all three of you are doing. And I think I'm more of an outlier because I'm not religious in any way. I don't like big pharma. I think this is a extreme civil rights issue of with so much suffering behind it, as Don and other people have alluded to. This is causing such pain for people across the board. How can that be communicated to politicians without turning them off? Because it just seems to be such a civil rights issue that it would be enraging to deal with people who are coming at it, I think, from a different angle. So I wonder why New York hasn't passed that over all these years, and what can be done finally to make this happen.
So I kind of want to put it in perspective a little bit. The bill was introduced in 2015, and for any of you who follow large social change efforts in New York, it takes years. You know, I mean, let's look at the Child Victims Act, which just passed, what was it, last year, like 2 years ago. We lost a whole year with COVID, but the year before that, Child Victims Act passed. That allows survivors of sexual assault at the hands of clergy and other people in power to bring lawsuits against their abusers years later. That measure had been pending in the legislature for decades. Decades. Marriage equality, at least 10 years. The Reproductive Health Act codifying Roe versus Wade, 14 years. We still don't have a comprehensive sex education bill in New York. You know, this stuff takes a long time. New Jersey, it took 7 years. Connecticut, I told you, was on the verge. 27 years that bill's been pending. So I say that to give you some perspective, but I also know, as someone who deals with dying people, that every single year the legislature fails to act, the bodies pile up. That's why the urgency in my voice. That's why I say, if you agree, and it sounds like you do, take action. You know, click that link. I guarantee you, the minute you click that link, and I don't want to scare you, but the minute you click that link, you're going to get some emails from us telling you about the next thing you can do to take action. You can always opt out. If you're like Mary, Dr. Mary Applegate, you don't opt out, you stay with us and you do thing after thing, and then we keep asking you more. But you can opt out of those emails. Send the email now, find out how it feels. We'll send you more asks. We'll tell you how to get involved. We're gonna do a virtual rally on April 14th when they come back from break. We're gonna make a demand of the legislature to pick this bill up and pass it.
Corinne, you're doing a rally April 14th?
We are.
That's my birthday. That's the day this queen was born.
We'll have to honor you.
Well, that's good luck for us, I think.
Awesome.
Any other questions?
Yeah, there was another question. You know, how could groups, you know, such as like the People's Health Sanctuary in the North Shore area, which is predominantly economically impoverished area, high percentage of people of color, you know, those who Donna shared, so powerfully shared the disparity of access to resources. How could groups like that share resources with these communities, talk about these issues? And, you know, maybe I'll just add on to this question, especially in marginalized communities, especially communities of color, there's always this tension of access being held back from those communities. So like care being held back, but then also asking this larger question of actually what kind of care, what access to care do you want? And, you know, are there different ways of kind of bridging that tension?
Donna, do you want to take this one? I have some ideas.
Sure, we can tackle it together the way we normally do, Corinne. So my ideas is to pass out the resources we have one-on-ones, or if it's another organization that reaches out to these communities, make sure because you can get that planning guide electronically and send that along, and then cultivate those discussions. I think too, as a medical provider, Xavier, I'm so glad you're asking the question. I think sometimes we just have to start from a perspective when you're dealing with disadvantaged communities of trust and acknowledgement. Sometimes acknowledging the problem, even if you don't have the answers, goes a long way. And so I think that's the cultural competency part. When you're dealing with those from diverse backgrounds, whether it's racial, socioeconomic, they don't feel empowered to ask for second and third opinions. They don't feel like they can question the doctors or say, I don't believe in what you're telling me. And so having that conversation and building that trust, it takes time. But I think the beginning of it is having a very culturally competent introduction to say to if you're a medical provider, and just not the doctor, the nurses, anybody they encounter from the medical profession, I'm aware of the distrust. I acknowledge that it's there, and I want to do something about it. I think when, especially older people, for example, my mother told me about the night doctors. Xavier or Mary, have you ever heard of something called the night doctors?
Well, nowadays there are often people called night float so that doctors don't have to be there 24 hours, but it sounds like that's
Dr.
a fairly
Mary,
new
this is
thing.
different. No, this is
Yeah.
different. The night doctors started during the Civil War, and
Oh, very
they come
different.
at night and take the bodies of African Americans. Some bodies would go to medical schools to be practiced on.
Uh-huh.
Some people were just sick. They had not died yet, and they disappeared. And the night doctors went on even into the 40s. And it was suggested when Henrietta Lacks went into the hospital in the 1940s in Baltimore, people were talking about the night doctors from Johns Hopkins. My grandmother used to tell my mother, if you don't behave, the night doctors are going to come get you. My mother was afraid of the night doctors, but she didn't even know what they were or who they were. So this mistrust comes from generations of, right? And so it just takes that level of sensitivity and awareness and competency to sort of, on the medical provider talk, acknowledge the issue, and on the patient part, for them to be empowered, to be vocal, and to ask questions. It's going to be that marriage of.
Donna, do you see a tension between people not wanting to have this conversation or wanting to get the care, but also feeling like if I sign on for it, you're going to keep things away from me, just like they did in Tuskegee and
yes, that's definitely there. That is definitely there, and they're scared to talk about it. I graduated from Tuskegee University. I've never had that conversation with a doctor, but I have felt, well, I know I was discriminated against by a doctor, but I never felt, this was before this job, empowered enough to say, hey, this is what happened in my community, and I don't want it to happen to me. And what do you all do different? And I'm going to tell you something else. With that COVID situation, when that African-American doctor died the way she did, forgive me, I don't remember her name, but I'm sure you all know what I'm talking about.
Dr. Susan Moore, and we did a program about her on the radio. I'll put a link in.
That really resonated with people of color. If a doctor of color felt that she did not get fair and equitable treatment,
what's everybody else's chance?
Exactly. And so I think, going forward, people just need to be open and honest on both sides. That trust has to be built back. And it's going to take
ask questions instead of coming in and saying, I know what you need.
Yes, that is the wrong. That is the totally wrong approach. Dr. Bear, you hit it right on the point. Ask questions. And do a little probing and getting to know and building. In the diversity and inclusion world, we talk about building bridges to people so you can reach them where they are. And different people are in different places, right? So you got to build that bridge, and then you have to create dialogue, which is not one person telling the other person, but it's finding that synergy and that meeting place. So you got to be a builder of bridges, a director of dialogue, and you have to create that community where they feel safe enough to share.
I think we just have one last question, and I just wanted to bounce on the last things you were just saying, because I think you're already starting to answer it. But maybe this can be our closing question, but how can we change the cultural biases against talking about death, biases which are so prevalent in our country and others, small things to large measures? And I feel like you're already starting to answer that kind of meta question.
Corinne, do you want to take that, or Dr. Mary?
Why don't you start, Dr. Applegate?
Well, I mean, part of it is that we just need to start making it happen. And well, I've been doing a lot of volunteering for our county health department, giving COVID vaccines at the big arena, and there was a striking, especially early on, striking lack of African American patients in the room. I mean, we were seeing like 1,000 patients in a day, and there would just be a scattering of people in the waiting area after they had their shots. And I talked with a friend of mine when I saw him there, and we talked about what we can do. And so he had some excellent ideas, and I had a conversation with the health commissioner, and she had actually already started to do that kind of work outreach with the African American community in various parts. But then a couple days ago, I was at another one of these big events, and I was in charge of the after shot area. We give out orange stickers saying, "I got my vaccine," and there was an African American man who came, and he had put his sticker right there. So I thought, I need to go talk to him. And he said that he was just going to talk to all of his friends, his family, his neighbors, everybody about how important it is, because there's a huge amount of vaccine hesitancy. And it's the same kind of hesitancy about talking about end of life things, because there's suspicion that maybe it isn't the right thing for me, or maybe I'm missing out on things. So he had taken it on as his personal mission to spread the word in his community. And I think the more people we can get to be ambassadors like that, the better. Just ambassadors for talking to your family about your end of life wishes, period. You don't even have to start with the talk with, well, what do you think about medical aid and dying? Just, right. You're going to die, I'm going to die. What do you want that to look like? Make it a more normal thing.
And how do you make sure that your wishes and values are respected?
Right.
You can no longer speak for yourself.
Choosing a solid proxy for yourself, like Donna was saying, her best friend is, but what if her best friend and she suddenly something happens and you're not on speaking terms? She's not the one you want to be making your end of life decisions. So, but choosing wisely, and like with the other conversations, returning to them again and again, at least in your head, and making sure that your wishes are up to date and well spelled out.
And so for me, as I go around the country and I talk to various organizations and various communities, what I tend to say is, talking about death ain't gonna kill you, right? The mere mention of it will not stop your heart from beating, but not planning for it could hurt you and your family for decades. And so we begin there, normalizing the conversation. And for weddings and divorces and graduations, other than being born, this is probably the most important thing that happens to you.
Yeah, and it's going to happen to everybody.
Regardless.
No two ways about it.
If talking about death killed you, Donna and I would be dead so many times over. So many times. Xavier, I think we've got some closing remarks. I'm so pleased with all the questions. This has been fantastic.
Yeah, this is great.
Wonderful.
There are a million questions more, but I think this is a great way to get started. And thank you all for your information and sharing your stories. It's such a beautiful experience. And I just want to give some announcements, just some things that are coming out of the sanctuary. Echoes from Lock One world premiere. It's gonna be tomorrow in the Environment to Film Festival of the Capital Region, which is a pretty exciting event. We also have our Coming Out of Darkness altar in Freedom Square, which is right next to the sanctuary. That's been organized by Nancy Weber, among another team. That has been something that we started after the the winter solstice, and we've decided to keep going throughout the whole spring as a place for people to offer remembrances of those we've lost in the past year, in the past lifetimes. But also we're looking for people to help us with tending the altar. We are really trying to make it a litter-free and organized space, and people have been nice enough to donate food, and we're even highlighted on Spectrum News. So if you are interested, just email info@mediasanctuary.org. Also, we're looking for, with spring will eventually come, regardless of how we feel about the cold right now. Volunteers for the community gardens, the Collard City Gardens, right next to the sanctuary on the other side from the Freedom Square. So again, email the info@mediasanctuary.org. And upcoming, there'll be community events about community water and soil testing that will be done through the Nature Lab, and hopefully soon, maybe sometime in the summer, the actual Nature Lab building will be open. And there will be a few events coming in the springtime, April through May. These are still to be confirmed and to be determined, but you can check mediasanctuary.org for further events. We have an email list, the People's Health Sanctuary. And again, we are growing our network of people through these online events as well as in-person events. If you'd like to sign up for our emails as we move forward into the spring and hopefully move forward with the big fundraising campaign and moving into our new space in the Nature Lab sometime in the summer, fall, please sign up on the email list there. And as well, the Sanctuary has been running nonprofit and on a bare bones budget for almost more than 15 years. If you're able to in these difficult times, please consider donating to the Sanctuary. And I just wanted to end with a couple lyrics of a song that I heard the other day. And I work in the ER, and unfortunately see a lot of death and see a lot of heartache, but also see a lot of joy. And I heard this song on the radio coming home once, and to be honest, it brought me to tears. And I think it really exemplifies this idea that we, in order to be alive, means to die, and that even though our culture runs away from dying, it perhaps is what makes life beautiful. And he starts off, it's knowing that this can't go on forever. Likely one of us will have to spend some days alone. Maybe we'll get 40 years together, but one day I'll be gone, or one day you'll be gone. If we were vampires and death was a joke, we'd go out on the sidewalk and smoke and laugh at all the lovers and their plans, and I wouldn't feel the need to hold your hand. Maybe time running out is a gift. I'll work hard till the end of my shift and give you every second I can find and hope it isn't me who's left behind. So just something to think about. And thank you again for spending your Friday nights with us, talking about death and dying and dignity.
Thank you.
Take care. Have a great rest of your night and weekend.